everyone, I'm Olga Biaberti, and welcome to this special edition of The Balancing Act, Behind the Mystery. Today, how the gut can play a role in a serious kidney disease, and what you need to know about sickle cell anemia. The Balancing Act starts right now. In the United States, sickle cell disease affects an estimated 100,000 people. Patients with severe sickle cell have a very poor quality of life, with frequent pain episodes and trips to the hospital. Now, there is no universal cure for the disease, and patients typically only live to their 40s. At 47 years old, Carla Howard has already outlived the average life expectancy. She has made a decision to do everything she can to make a difference for the next generation. Let's go behind the mystery.
Living with sickle cell for the last 47 years of my life has allowed me the ability to definitely make sure that I'm advocating for individuals. I have the pleasure of reaching out to parents of newborns who have been diagnosed with sickle cell to give them the perspective of someone who lives with sickle cell on a daily basis. I just try to reach back and help someone else to make sure that they can live a much fuller life than I did as a kid.
The Balancing Act met with Dr. Poonam Malik, director of the Comprehensive Sickle Cell Center at Cincinnati Children's.
Sickle cell disease is an inherited mutation in the hemoglobin gene. Hemoglobin gives oxygen to the tissues. Normal red blood cells are round, donut-shaped, and flexible and go smoothly through blood vessels. But sickle red blood cells are hook-shaped or crescent-shaped every time they give up oxygen. And they clump and clog blood vessels, limiting blood flow, causing intense pain and organ damage. Fetal hemoglobin is an anti-sickling hemoglobin that is present at birth within the first 6 to 9 months of life. The gene that makes fetal hemoglobin switches off. In sickle cell disease, this is when you start making the mutant sickle hemoglobin. So if there is some amount of fetal hemoglobin, it prevents the sickle hemoglobin from clumping and changing the shape of red blood cells. Sickle cell disease is a lifelong debilitating disease. They can develop complications like acute chest syndrome, stroke, chronic anemia that causes fatigue. Children with sickle cell disease are more prone to infections and infectious complications. And the disease just slowly erodes their organs. So over time, they develop chronic organ damage and then loss of function of different organs.
Growing up with sickle cell was very tough. Subconsciously, I dealt with a lot of angst and fear because I didn't know when sickle cell would arise in my life. Through my high school years, I was hospitalized at least 7 times, mostly during the holidays. You know, I got to know a lot of people on the floor who was there dealing with the same things I was dealing with, and forming that type of community helped, but it still was difficult.
Sickle cell pain crisis causes sudden onset, very severe pain. A lot of this pain is confined to the limbs and the back. Patients often get admitted for painful crisis and they're in pain for days. And this requires them to be on lifelong painkillers. So the common treatment for sickle cell disease is really treating the symptoms. So if they have pain, we give them pain medicines. If they have acute chest, we treat the symptoms of pneumonia. We will give them oxygen. We might even do an exchange transfusion so that we can reduce the amount of sickle hemoglobin in their blood.
Most people see this vibrant smile, but don't really understand that I'm probably in some sort of pain in that moment. As an adult, I have been in the hospital 5 times, with 2 of those times leaving me in the hospital for up to 2 months. Sickle cell is not something I wish on anyone. It is not for the faint of heart. It's difficult because of the stress that it brings about, the uncertainty, the life expectancy. I personally want to continue to see sickle cell treatments advanced so that the younger generation can have a better perspective of life than I'm living today.
Coming up, a potentially one-time curative therapy in clinical trial. Stay with us. Welcome back. The current management strategies for sickle cell have their limitations. Let's go back to Dr. Malik for more.
The only definitive curative option for sickle cell disease is actually a bone marrow transplant. In bone marrow transplant, you need a matched donor, which is a limitation. The second thing is, despite the best match, you can have immune side effects. And the third major thing with bone marrow transplant is that you have to wipe out all the diseased stem cells with very heavy doses of chemotherapy. But these are available to only about 15% of patients. So 85% of patients with sickle cell disease do not have a curative option currently. And they are on disease-modifying therapies like hydroxyurea, a medicine that can increase the fetal hemoglobin. It has to be taken daily, and it has to be titrated to the right dose that would not cause side effects. In some patients, it doesn't work as well. It doesn't increase the fetal hemoglobin. Patients want a curative therapy that is a one-time treatment, and then they don't have to worry about their sickle cell disease.
Research from Dr. Malik's lab at Cincinnati Children's is providing hope. She's developed a one-time potentially curative investigational gene therapy called ARU-1801 that is currently in a clinical trial.
I wanted to develop a therapy that would be universally applicable to all patients. For all blood disorders, you can actually genetically correct the blood stem cells and give them back to the patient. The advantage is that these are the patient's own cells, so every patient has this option. And because they are the patient's own cells, they do not come with the immune side effects you get from bone marrow transplant. This is a one-time but lifelong therapy. The way gene therapy is done is that we first collect the blood stem cells, and that's just like a blood donation procedure. These stem cells are then genetically modified. A few weeks later, the patient gets a dose of chemotherapy, and then they get infused with the gene-modified stem cells. After the patients get their stem cells, they make blood cells from the genetically modified cells. ARU-1801 is an investigational gene therapy for sickle cell disease, where an anti-sickling fetal hemoglobin gene is delivered into blood stem cells. That is a potentially one-time curative therapy. We collect the blood stem cells and modify them with an anti-sickling fetal hemoglobin gene, and we give them back to the patients with a single lower dose chemotherapy that has much fewer side effects but does produce the desirable anti-sickling effect. All gene therapy and gene editing trials for sickle cell disease are currently investigational therapies, and they are all in clinical trials. It is very important for patients to enroll in clinical trials because that's how we make progress. We learn a lot from clinical trials because they are done systematically and in a very controlled manner. They have a lot of oversight by regulatory agencies and the FDA so that they are done safely.
If I'm personally asked to participate in a clinical trial that I am eligible for, I fully participate. Clinical trials is definitely the one thing that can help future generations of sickle cell disease patients. My hope is that there becomes a treatment that is universal across all individuals living with sickle cell, just to give this community the gift of life.
For more information, you can visit momentumtrials.com and clinicaltrials.gov. You can always visit our website, thebalancingact.com. We'll be right back. Although it manifests in the kidneys, most scientific studies have found that the cause of this serious kidney disease begins in the gastrointestinal tract. As the disease progresses, up to 50% of patients end up at risk of developing end-stage kidney disease and possible dialysis within 10 to 20 years. Now, currently, there are no approved treatment options. Let's go behind the mystery of IgA nephropathy.
I live in Westbury, New York. I love to play golf, love all sports. I met my wife 22 years ago. We've been married to be 20 years in February. Back in 2005, I went for a routine physical. After the physical, I received a call from my doctor saying that something was off in my urine and needed to be retested. She called me and said, I believe you have something wrong with your kidneys. I followed up with a nephrologist and he told me I had IgA nephropathy. Basically didn't say anything else. It wasn't, this is a rare disease, you have something to worry about, you should monitor anything else. It was, I'll see you in 6 months. Later that year, I decided to go for some more life insurance. The results came back that I was denied for the life insurance due to IgA nephropathy. And since the doctor told me it was nothing to really worry about, this was very shocking to me, seeing this outcome.
The Balancing Act met with nephrologist Jonathan Barrett of the University of Leicester in the UK to learn more.
IgA nephropathy is a disease of the fine filters of the kidneys, and these filters are called glomeruli. And in this condition, they get deposited with this protein called IgA. When this IgA protein deposits in the kidneys, it leads to inflammation, which then leads to scarring and then leads to loss of kidney function. And in the most severe cases, this loss of kidney function means patients need to have dialysis or a kidney transplant. So the challenging thing about IgA nephropathy is most patients don't actually know they have the disease. So most patients are diagnosed by chance, and actually the way that we identify they have kidney disease is through doing tests of the urine or tests of the blood, or potentially picking someone up who has high blood pressure. There are the rare cases where patients may present with obvious blood in their urine when they pick up a cough or a cold, and will trigger a referral to a kidney specialist. Most of the patients I diagnose with IgA nephropathy, it comes as a massive shock to them that they actually have a significant kidney disease. The patient is then tasking me with what can I do about that? What treatments are available to prevent my kidneys from failing? And my honest answer is we have no effective treatment, and so it is a great deal for those patients to deal with when we give them the diagnosis.
Having a rare disease, I really did not know what to look for. Looking back now, you see what the signs really were. I was probably more tired than I should have been. I did see some foam in the urine. I was stable for a few years, after which the protein in my urine started to increase. The doctor at that time said that there was no treatment, there was no cure for IgA nephropathy, we just have to manage the symptoms. The doctor suggested a high dosage of prednisone as a way to try and manage the progression of this disease. I had many of the side effects of prednisone. The weight gain, the irritability, the insomnia played a major factor in my life as far as not having the energy to go out on weekends or evenings with my wife or friends. Playing golf came to a screeching halt. So this management of the disease had many side effects that were worse than could have been imagined before.
A patient's care plan can include a healthy lifestyle and medication management. Immunosuppressives aim to reduce inflammatory response and turn off the production of the abnormal IgA. Non-immunosuppressives are used to lower blood pressure and reduce the amount of protein in the urine. None of these options, however, are enough to protect the kidney from future decline.
Patients tell us that actually the side effects of taking these drugs can often be worse than the possibility of developing kidney failure. And this means we have a significant unmet need in the treatments we can offer our patients. They want new therapies that are safe, that they can tolerate taking, and that we can show will protect their kidneys against future deterioration and stop them needing dialysis or a kidney transplant. So we know in IgA nephropathy that actually the kidneys are an innocent bystander in this disease because they are having to deal with this abnormal IgA that has been delivered to them every minute of every hour of every day. And so concentrating a therapy directly on the kidney may well control the inflammation within the kidney, but it doesn't solve the problem. And therefore, if we hope to cure this disease, we need to target therapies at the very beginning of this disease, which is the production of this abnormal IgA.
IgA is an antibody whose main function is to line the surfaces of the mucosal membrane, where the body's surfaces are exposed and come into contact with viruses and bacteria. IgA is secreted to stop bacteria from entering the body. As the largest mucosal surface, the gut is the major site of IgA production.
Now, in IgA nephropathy, what we found is that the IgA that gets stuck in the fine filters originates from Peyer's patches, which are very organized parts of the immune system that are situated within the small intestine, called the ileum. And to solve the problem, we need to target the production of the abnormal IgA. Because we know that if we plumb a brand new kidney into a patient with IgA nephropathy with a kidney transplant, that kidney is just as much at risk of IgA nephropathy as the original kidneys were.
The hardest part is waiting for the lab results, and then the panic of opening to see how or what your kidney function was going to be this time, knowing that there's no cure, no treatment for it. Even if the blood work is bad, what's the next steps? What happens if I get to a point where I need dialysis and can't work? Those are all the things that keep you up at night, thinking what's going to be the future for me as everybody in this disease advances at a different level.
Unfortunately, despite doing everything he could, John's blood work showed the prednisone was no longer working. He was referred to an IgA specialist who started him on a different management plan, and while it worked short-term, it did not last.
The IgA specialist gave me two options. One was to go back on prednisone or to join a clinical trial for patients with IgA. In looking at the clinical trials that were available, I decided to go with the clinical trial that was best for me. My results from my last blood work while on the clinical trial, my GFR has been stable, my protein has decreased dramatically. So this clinical trial shows good progress for me. It helped relieve a lot of stress in my life.
It is a truly global effort to find a cure for this disease. It is a real testament to the patients who are desperately keen to help with this research. And my discussion with the patients is always to give them the opportunity to be involved in research of new therapies that could ultimately deliver us treatments for this disease.
I was asked to sit on the board of directors for the IgA Foundation of America. I got asked to sit on a panel to speak to the FDA regarding research, the trials that were going on in order to help bring those to market sooner. In leaving that panel that day, very emotional, listening to some of the people who have terrible lives, and you could not imagine how lucky you felt leaving there. It makes you wonder really what tomorrow brings if there is no true treatment or other way to manage this disease.
For more information on IgA nephropathy, visit IGAN.org, or you can go to our website, thebalancingact.com. We'll be right back. Thanks so much for joining us. Remember to head to our Facebook page and our website. Follow us on Twitter. Be safe, and we'll see you next time.